Hello, and welcome to this Beyond Clean virtual conference. The speakers for today's conference, the sponsors for today's conference, and the Beyond Clean team are all so excited that you're here. If this is your first time joining us for a Beyond Clean virtual event, I want to call your attention to a couple of event functions. All of the windows on your event screen are movable. You can shrink them, you can enlarge them, you can move them, whatever you need to do to create the event feel that works best for you. In the upper right corner is a resources tool. Download conference sponsor information and the resources and links that your speakers have provided for you, as well as instructions for obtaining your CE certificate for the day's event. On the bottom left, you will see a Q&A or question and answer tool. Any questions that you have for the speaker during each session can be submitted to them using this feature. Our speakers today will bring you a wealth of knowledge, and all of their information can be found in the speaker bio tool on the right side of your screen. Along the bottom are the icons for each of the windows as well. Clicking these will minimize and maximize each window. This will be an action-packed conference, and there will be 15-minute breaks between each of the sessions. So feel free to grab a snack, check on the dogs or the kids, assemble a tray, do some jumping jacks, whatever you need to do before joining us again. Good morning, everyone. Well, good morning in Minnesota anyway. Perhaps it's afternoon or evening where you are. Regardless, we are so glad that you're tuned in today. Welcome to the Resist Conference. My name is Lindsay Brown from the Beyond Clean team. I want to thank you for joining us today. We are wrapping up two incredible and important weeks, International CS Week and International Infection Prevention Week. You all are here today because you are dedicated to standing up against superbugs and surgical site infections. And we've got a powerhouse lineup of speakers for you today to learn from, to engage with on that very topic, standing up against superbugs and surgical site infections. I want to thank 3M for sponsoring this event. Their dedication to education is the reason why this 7.5 CE event is free and open to anyone who wants to learn globally. Dr. Wava Truscott, our first speaker today, has over 30 years of experience in various aspects in the medical sciences. She holds a doctorate in comparative pathology with an emphasis in microbiology, immunology, and pathology from the University of California, and an MBA from the University of Laverne in California. She is going to discuss the causes and complications associated with ophthalmic and neurosurgery that have been associated with inadequately reprocessed or damaged surgical instruments. So a super light topic to start the morning, to start your Friday morning. Let's get into it, everybody. I am so excited. I'm a Wavite. I adore Wava. I think she's brilliant. I'm so excited for her to kick off this conference. So without further ado, I'd like to introduce Dr. Wava Truscott. And Wava, I think your camera might still be muted, so if you can unmute it really quick, that'd be great.
Thank you, Lindsay. I appreciate it very much.
And there you go. Welcome. Perfect. I hear you. I see you. It's a good morning. Take it away.
Sorry about that. Thank you, everyone, for joining us. I hope that I can launch this in a proper direction here as far as the program goes. It's going to be an exciting day. I have no conflicts of interest to declare. I do have objectives. The objectives today are to list post-surgical complications that can be associated with inadequately processed ophthalmic instruments and describe the really extensive attention we need to have to ophthalmic equipment or devices, instruments, to make certain that we are not causing these complications. We're going to identify post-surgical complications associated with prions. That is the other disease we're going to be talking about today with brain surgery. And also summarize the steps required to ensure appropriate and adequate reprocessing, especially with this specific disease of prions. First, I want to take an opportunity to really grasp the amazing difference that we have among the different animals. We all have, most have eyes, but what's different and what's a magical component of all of this? As we share that sight, First of all, the light photons that we see go through the convex area of the cornea. And as it goes through there, there's a space that's called the anterior segment, and is very important as we get into the rest of our talk. Then it goes into the pupil, and it goes back to the eye. But as you can see, the leaf that's there, it takes the light because it's convex, and it allows the light to go through, and it crisscrosses as it goes through to focus then on the fovea, which is the back part of the eye, the place that we really see most discreetly. And there it turns, the image is actually upside down. That then starts to, as we go to the next slide, I need to get ahead of myself here. That light then hits the retina, does a lot of communication with various parts of the retina, and then goes into impulses, and those impulses go into our optic nerve to the brain. That interprets it and turns the image right side up so that we can see what we're doing. All of this while we are just sitting there looking around, trying to enjoy and see many, many colors. Now this is fascinating in that as it hits the retina, you can see on the upper left, there are cones and rods. The rods help us to see black and white distinctly. The cones are colored only 3 colors: blue, red, and green. Now there are about 6 million of these cones to only 120 million of the rods, but these cones are only come in 3 colors, and when they mix together, it gives us all of our sight. It's not like mixing paint, where you put 2 colors together and we make our painting colors. When it goes through light, it comes out differently. For example, yellow, when we see yellow, it actually comes from the red cones, while the blue, red and green cones, while the blue ones don't get an image. They don't get an electrical impulse. But all the variations of how much each is excited, if you will, by the color coming in, is how we see color, the various phases of those colors. Look on the upper right, you'll see a slice through the retina. Look at all the different layers that are in our retina that is only about 0.5 millimeters thick. You can imagine if you had to do surgery there. Believe it or not, they're now doing robotic surgery. They're able to get to separate doing amazing surgeries. In the rods and cones, you see I have them labeled in yellow. Okay, that's where the rods and cones are. The light is coming from the top part into that area. In the very left-hand portion of the retina, you see an area that's called optic nerve axons, and that's where the electrical impulses that come from the light, that comes from the altered cones when they see the light and they start to express the impulses. Those actually go through that pathway into the optic nerve. So it's really a complex thing, and we take it for granted all the time that we can just see. It's just amazing how it occurs. Now, it's not the same for all of the animals. If you'll see on the left, we have a human in a bullfight. You can see the bull is headed for the red cape, but as you see at the bottom, the bull can't see color. But he sees the movement of the cape. So that's something that we all learn. And besides that, now that I can see our matador, pink and red just don't go together. Just don't go together. But that's his taste. All right, then in the next one on the upper portion, you'll see the mosquito. The mosquito doesn't see color so much as he can actually see things like carbon dioxide. He senses the sweat and sees the warmth, as you can see. And that is where he finds where his food is, as the blood meal, if you will. On the right, you'll see how we can see in the dark a mouse. Now, a snake sees infrared thermal imaging. So he sees the animal totally different than we do, but that is his meal. And in the center, you'll see the comparison between the visual different colors, the prism, if you will, that a human sees versus a bee. A bee doesn't see so much in the red zone as he sees in the ultraviolet zone that we don't see very much of. Pollinators like bees see the ultraviolet markings on the flower. We can't see 3 colors below on the right. We see what's on the left. The bee sees what's on the right and use it like a landing field where he goes towards the purple that you see in the center, where his meal is. It's just fascinating how we have so many differences. Then we have color perception here of our trusty animals, such as the dog. We see a dog on the left. The dog sees us in the very muted tones. Probably not quite as interesting as we see the dogs. And then the center, remember we talked about the human, we only have 3 colored cones, the red, the blue, and the green. Well, the spotted mantis shrimp has 12 cone colors. So he sees a multitude of nuances that we don't see as far as color. I mean, it seems kind of wasted in the ocean, right? But that's the way that it is, or in the water. On the right, the peacock we see is a beautiful, beautiful combinations of colors. Grandpa used to have peacocks. But on the right, the peacock only sees purple. And then at the bottom, we're looking at indoor light. A cat's vision of indoor light is very muted, very blurred. It's kind of sad. And on the right, at nighttime, you can see much more, he or she can see much more as far as light in the darkness, but still having that somewhat blurred vision. Now, the uniqueness of some of the sight is just amazing. Compound eyes, thousands of tubes, and each has a lens and a pupil near the top part of it. And then the tube comes down in towards the brain. Sight tubes are wrapped around the insect's head so they can see 3-dimensionally. Each of those tubes, and in this case the dragonfly has about 30,000 lenses in his eyes, and each of them gets a little glimpse of what's happening. And those all go together. They're interpreted in the brain in one area to see a mosaic of what's happening around him. That's why it's hard for us to sneak up on a mosquito. He can actually see in the back of himself as well. And thus he has surround vision, as the dragonfly has in this picture. So why the extra medical focus now on eyes? Why is it such a big deal for me to address this right now? It's because we have a really aging population. And they have about those that are over about 64 have over 5 times the amount of vision loss than you would have in younger years. Now, this is skewed. This is by our own National Health interview survey. It's skewed in that they didn't go into old folks' homes or long-term care facilities. So they miss a lot of the elderly population. So this is a very low number. It's many more than 5 times the amount of vision loss that they have. And our population is really increasing as far as the aging population. In 2030 to 2040, that population is going to represent 1 out of every 5 individuals will be over the age of 65. And it is estimated by ophthalmic organizations that in 2030, that's less than 10 years from now, that vision loss rates will double. Now, what is it that the elderly population is really, what's happening to the eyes right now? The peripheral vision, they begin to lose that. I hate to say that, but we begin to lose that peripheral vision. We have reduced pupil size, so we aren't able to take in as much light, which means we need more light. I've actually come to the point where instead of having the yellow lights for that cozy atmosphere in the living room, instead I have to have the brighter lights so I can see what the heck's going on. Then we have reduced color vision, the need for more light, as I noted. Fluctuating vision seems to be very clear, and then after a while it's not so clear, and then it clears up again. They have dry eyes, which is a lot of individuals are suffering, finding out that the drops make a huge difference in the clarity and the vision and the comfort. Vitreous detachment, which just occurred to one of my colleagues after cataract surgery, actually fighting a web that she saw, anticipating that was a spider web in front of her, and she just couldn't get rid of it. And it turned out it was a large chunk of the vitreous precipitation, or detachment, rather. The decreased night vision, sensitivity to glare, it's harder to drive at night, and reduced depth of perception, increasing the probability of falling, which is another fear of the elderly. There are 4 major age-related eye diseases: age-related macular degeneration, cataracts, diabetic retinopathy, and glaucoma are those 4. And as you can see in the pictures in the center, for the age-related macular degeneration, you actually have that blurring right in the center. So you're trying to look at things, you'll see that people are kind of moving to the side a little bit as they have better side vision than they have right in the center for those who have this particular disease. Then you have cataracts, or it gets blurrier and blurrier with time until they finally decide it's time to take them out, replace them with the artificials. The diabetic retinopathy breaks apart, which is very detrimental and finally really declaring a blindness for individuals. And then you have glaucoma. So these are the 4 major ones that we'll have different treatments and surgeries with. And as we do so, each of those are related to one of 3 different types of complications that we can actually have impact on. One would be the toxic anterior segment syndrome, one is the non-infectious endothelmitis, and one is the infectious endothelmitis. And you can see each of those 4 areas for different, each of the different complications are related to. So let's look at each of the 3 complications. For the toxic anterior segment syndrome, and you've probably heard it most recently, or most frequently, as TAS. It's rare, but it's potentially sight-threatening. The acute inflammatory response is a non-infectious condition, inflammatory reaction to something toxic that's gotten into that anterior segment that we talked about the very second slide, I guess it was. Again, in the picture, it's between the cornea and where the pupil is. So it's just that area, which would be the anterior chamber. We have, or segment. The symptoms appear 12 to 24 hours after surgery, and that's very important. That's the only one that really occurs that rapidly. 12 to 24 hours after surgery. It's urgent attention. Anything we can do to help our patients understand that if you start to have problems, call us immediately. And if you make a card for them to call or a piece of paper to hand them so that they know, make sure that they are extremely large letters because it's so hard to see after they've had the surgery. Urgent attention, time to treatment makes a huge difference in the sight outcome. After treatment for TAS, the sight recovery ranges from 20/20 to total blindness, and that timing is a large part of the difference. The after treatment, the recent large eye conference was held. They did a survey and asked anonymously how many had had cases of TAS. And they found that the facilities, the individuals, 52% had seen at least one case of the severe TAS, and 7% had seen greater than 5 TAS patients. This is... the reporting is not required in the U.S., so that you can imagine it's probably higher than even this. TAS etiology, it's caused by, and this is important because this is us, it can be caused by residual disinfectants, detergents, enzymatic cleaners, even little pieces of enzymatic cleaner that's left it's a combination of the particle as well as the activity can cause the initiation of the TAS. Heavy metals, lint and particulates, endotoxin. Endotoxin, they're parts of dead bacteria. So we may have sterilized something and cleaned it totally, but endotoxin, as well as some of these other exotoxins, but endotoxin is very resistant to heat and other forms of disinfection. It stays around quite a bit. You can have a whole course on endotoxin. Mineral deposits such as hard water or dried on salts, the residues from the sterilization process, viscoelastic residuals, the lens matter, vitreous, eye tissue, etc., on the various devices. Cement, seal on bags of irrigating solution have leached out and ended up going into the eye solution. Injections containing preservatives, topical eye solutions, and particulates. All of these have been identified with cases of TAS. Now, looking at the non-infectious sterile endothelmitis, it's very similar as far as what happens is inflammatory-wise, but its positioning is not in the anterior segment syndrome. So non-infectious endothelmitis is an inflammatory condition in the interocular cavities, the aqueous and the vitreous humor, so that back portion, caused by various agents that elicit an immune response despite there being no pathogens. Very similar to TAS, but it's causes. And what are these specific ones that have definitely been associated with this particular complication? Residual chemicals from sterilization, preservatives in the vitreous injections. One of the things is just going too far. It's supposed to be just in the surface area or just into the sclera or various areas, but unfortunately is shot into the vitreous, so the needles goes too far. The endotoxin on instruments in the lumen, in rinse, injection solutions and drugs, disinfectants, detergents, heavy metals. Endotoxin sounds like I'm repeating myself, I know. Enzyme cleaners not thoroughly rinsed off, mineral deposits such as hard water, dried salts, sterile lint particulates, inadvertent interocular injections of specific types of medications, several times of which it has actually come from the pharmaceutical facility with particulates or some sort of preservative that is not friendly to the eye. The infectious endothelmitis, as the name implies, involves the actual bacteria or fungal infection, or in some cases parasite. The acute bacterial infection usually appears 4 to 7 days. For TAS was 12 hours to 24 hours. You know you've got something, it's happening severely. But with the bacterial infections, it's actually 4 to 7 days post-surgery. So it helps you in the diagnosis. The infection includes the vitreous and or the aqueous humor, so behind the eye, a portion of the eye. One of the most devastating intraocular surgery complications. It's rare, but 90% occurs in the post-cataract surgery. Cataract surgery that's the same thing with TAS, even more so. The aging populations, escalating cataract surgeries make the infectious endothelmitis public health concern because the greater than 40% have severe vision loss after it occurs. And the corrected vision distance is 20 to 200 or worse, including blindness. 33% reach visual acuity of 20/40, and it's considered, thank goodness, at least it got that good. Occurs up to almost 1% of the time, not quite 1% of the time. The rate is increasing at the same time the population is aging and thus requiring more surgeries. Exogenous and endogenous sources, 90% are bacterial infections, but the fungi and the parasites also can occur. These are just the various organisms. I won't go through them, but it helps you to divide it into acute, those specific organisms on the left, and delayed, taking a little bit longer, even up to 6 days to show up with some of the bacteria and the fungi, which take a little longer to show response. So, what is the cause? As far as the infectious endothelmitis, contaminated interocular injections, this time contaminated with organisms rather than the chemicals, non-sterile surgical instruments, environmental contamination from the air, the staff, the fluids, the patients, the injections, patient non-compliance. And I know that there was one patient case where it was a family, not tradition isn't a good word, but practice, that when there was an eye problem, they always added milk, that it seemed to soothe the eye. Well, they put the milk in right after the surgery to soothe the eye. That had organisms in it, and that ended up causing severe infection. And there are very many other areas that lets us getting it wet when they've said don't get it wet, letting the organisms from the tap water in. Patient noncompliance, that's what we're describing. Filtering blebs of the initial infection site and the non-sutured openings seem to be very much more susceptible than those openings that are sutured. And suture tracks, however, can also be part of the villain, or the process, I should say. Prevention by the numbers. We're going to go through 3 sets now. Sterile Processing Department physical setup and flow, reprocessing, and the operating room environmental disinfection, air filtration practices, and lint and particulates. So going into that, first of all, let's look at a large center where they have multiple things going on, a hospital situation, for example, where you really want to come in, as you can see it up at the right, it says in, so they come in, deposit their soiled items, come through, they leave, and the decontamination area takes over, all in a nice flow so that they aren't going back and forth into the areas. And then up at the middle, on the right, you'll see, the eye instruments. It's going to be more and more emphasized, or it is more and more emphasized, that it really needs to be separate from the other things coming in. You've got orthopedics, or you've got a heart surgery, or you've got someone who's had some sort of infectious disease, all coming in at the same area. You want to make sure that your eye instruments are really separated, because just little pieces of things can cause all of the things, or many of the things that we've just talked about. And little residuals, perhaps in the water, that someone didn't clean out after the other instruments were processed in the ultrasonic cleaner, let's say, or the rinse water. So that is extremely important, and I'm really emphasizing it because it is so important, especially now that they're doing budgets for next year. It's really important to keep those things separate in all aspects of it. Or you may be in an area that's more like this. This is a specialty ophthalmic eye surgery center. And notice that they don't have as much room, at least in this particular example. So it's coming in, and then as it starts to, as you see, we've got right here, the items are coming in the bottom right, and delivered, and you travel along towards the left. I think it's supposed to, yeah, there we go. But please, please, please consider some way to divide things. Otherwise, as you are coming in with your dirty items, you may be facing the autoclave with things coming out if you don't have these chemical-resistant dividers or walls, whatever you can do to divide things. Same thing with the clean working area on the left. You want to keep that separate from the dirty things that you're cleaning right across from it. So those dividers will just block it, and not block it, but they'll divert the movement of the airflow. And that way you can more readily keep things separated and in the proper flow. Okay, now this is one thing, and I like to always show in my presentation somewhere where you can get the freebies that will really be educational. And this was the guideline for cleaning and sterilization of ophthalmic instruments, and by the various ophthalmic agencies. And so as I go into my talk, that's really what I am focusing on, and you can see the attachment there. I've already given Lindsay the presentation. She's going to have it ready for a handout that you can get as a download. The large TAS outbreak in 2006 in the United States led to the formation of a task force for TAS task force. Try to say that fast. And as they went into really studying the outbreak and going to the initial causes, they found that that there were several specific issues that primarily focused, first of all, there were 69,000 surgeries and 1,454 cases of TAS. They found out the three major reasons were inadequate flushing and rinsing of hand pieces, that's number one, use of enzymatic detergents, and that it's not the enzyme itself to start with, it's that it's not cleaned off afterwards, and we'll get into it a little bit more later, but whether it's the physical presence as well as the chemical reaction that it can cause, and use ultrasonic baths, especially in the hospitals that had for multiple devices. Strongly recommendations then, as we're going to get a little bit into the fine points now. All facilities should establish written protocols. They should be available to everybody and constantly updated as procedures and protocols change. Protocols and devices should be readily available for the staff, not just management, and updated as needed. In cases where you're really having a hard time with things that must be changed before an inspection occurs, be sure and have the ophthalmic team, the surgical team, investigate or go through things out also to see if there are changes that should be made or recommendations. I don't mean just before an inspection. Anytime they should be doing that to work as a team to make sure that we're doing everything correctly. Flushing instruments with lumens should begin in the operating room, and this is an emphasis where that teamwork can also be a huge help. Just understanding how important it is, the sooner they can rinse out the lumen, the sooner they can wipe off any of the debris before any drying occurs, makes a huge difference in the overall outcome. When sterile water baths are used for cleaning and soaking instruments in the operating room, keep them separated from the sterile instruments still in use. You don't grab the wrong one. When flushing the lumens, make sure the effluent goes into a separate area so that you aren't putting it back. There's a lot of times that they'll take it in, push it out, take it in, push it out, realizing they are flushing the lumen, but each time they're increasing the concentration of dirty water, basically, with what's coming out of the lumen. So make sure that you're pushing it out into another separate container. After surgery, keep the instruments moist until cleaning process begins to avoid the drying of the debris on the surface. So at the beginning of everything, coming out of the operating room, we want it to stay moist until it's actually in the hands of the decontam, and they're actually starting to process it. In decontam, if something happens, they also should be re-moistening the towel so that things don't dry out. Dampen, then cleaning area, once we get into decontam, dampen with a soft lint-free, and I realize we're saying lint-free, and sometimes, unfortunately, you need to use the word low linting, cloth, and soft brush to clean the instruments according to the instructions for use. Controversial. Guideline authors do not believe that enzyme detergent should be used for ophthalmic instruments. This is from the guideline. Some cases, if you had excellent rinsing and removal of the enzyme, it would not be an issue, and it was helpful. But also, what they're explaining is that enzymes are more for the bulk organics, with the viscoelastic and things like that in there. Very often the contamination are things that will dry on and things that will cause a problem, but aren't necessarily at high organic content. The enzymes that remove bulk normally in surgical instruments, which is extremely important, I believe, in using enzymes there. Tiny ophthalmic surgical devices and lumens make complete removal almost impossible or very, very difficult. Even a tiny amount of enzyme in the residual can cause TAS. Inappropriate use and incomplete rinsing after the enzyme detergents has been associated with TAS outbreaks, and also, as we saw, can be associated with non-infectious endothelmitis, depending upon where it's impacted in the eye. Manufacturers asked to address alternatives for ophthalmic devices in their IFUs so that you aren't then caught with, I didn't follow the IFUs because it told me to use enzyme detergents and I did not, and the inspector got upset. So right now there is work going on to have IFUs manufacturers validate alternative methods of cleaning without use of enzymes so that you have that choice. And then in 2014, surveys showed that enzyme non-users had 0.021 cases of TAS versus 0.027 for those who used enzymes. It doesn't sound like a huge difference, but it is for the patient who had TAS. Cleaning in the decontamination area. Okay, the first sentence is saying, took me off for a moment. Discard the brush after use. If you're reusing the brushes, make sure that you are cleaning them and disinfecting them and then sterilize them at least once a day. Repeated cleaning and rinsing may require to ensure the removal of all debris and ophthalmic viscoelastic devices and residuals, not just a once-over. It's really making sure that you keep doing it. It's very hard, even with good magnification, to see inside the lumen. Discard the effluent rinse, water so that only debris-free water is used for subsequent rinsing. Again, trying not to contaminate that rinse water. Volume and type of water used for rinsing, it should follow the IFU from the manufacturer. Many IFUs require critical water. What is critical water? Critical water is either sterile distilled water, reversed osmosis water, or deionized water. For most cleaning steps, used as a final rinse at least, if not for more different parts of the procedures, depending upon the IFU. Tap water contains heat-stable endotoxins, as we talked about before. They're the dead carcasses of bacteria, and gram-negative bacteria that release endotoxins on their death. But they're also present in the water as live organisms. Tap water may also contain calcium levels sufficient to leave calcium deposits in your devices, and that can also cause TAS. Ultrasonic cleaners. Okay, this is a really important part. Remove all the visible soil from the device before in the ultrasonic cleaners before use. Recommend ultrasonic cleaners dedicated to ophthalmic instruments. And you don't need a huge one. You can use a small one, so it's not a huge expense. But being dedicated to ophthalmics, I think, makes a huge difference in several of the complications that can occur. If used for surgical instruments in addition to ophthalmic equipment, should be emptied, cleaned, and rinsed before ophthalmic instruments to avoid cross-contamination. If used only for ophthalmic instruments, it should be cleaned daily. Use EPA-approved disinfectants to rinse, and with critical water sufficient to remove the disinfectant. Then use a final rinse of 70 to 80% ethanol or isopropyl alcohol. It really takes care of everything and cleans out the debris and takes care of the film that may have been left by the cleaning agents. Dry thoroughly with a lint-free cloth and then cleaned following the manufacturer's IFU before the next use. Very important area. By the way, if there is a problem with endotoxin, if you are ever cited to see a problem with, or a patient that has an issue, another recommendation would be hydrogen peroxide. the inside before you do your final rinse and alcohol, and then rinse again. So I know that sounds excessive, but it can make a huge difference. Ultrasonic units for ophthalmic use should be dedicated. Chemical reactions, and we talked about that in general as far as the cleaning, but also when you are putting instruments into the ultrasonic cleaner, you should never mix the metals, because the metals can actually react with each other, especially with the ultrasonic activity going on, so that you'll start to have breakdown and chemical reactions occurring. This is just how it works, which I always think is an exciting little video. Everything that's cut in little tiny areas, the bubble comes in and sucks it out, implodes it rather, and cleans areas that we can't otherwise clean. So it's a very, very important piece of equipment. Sterilizations, follow the device instructions for use for sterilization, follow sterilizers' recommendations for routine maintenance, for cleaning, for inspection, according to the sterilizer's recommendations, and document. Date, person, everything. Glutaraldehyde is not recommended because it's so toxic and it's really hard to get rid of to the nth degree. Low temperature sterilization should not be used unless it's validated by the instrument's manufacturer. With respect to efficacy of the sterilization, instrument functionality, and the potential of ocular toxicity. Ophthalmic instruments had narrow aluminum and brass components in this particular instance, but they decided to go ahead and use the cold sterilization. It seemed logical, it was faster, and it seemed like it would be a good idea to use. They used the gas plasma sterilization. It caused the brass to degrade into copper and zinc. And the instruments were used in the patient. They caused corneal decompensation, transplants, and blindness. A whole number of them, 6 of 8 individuals in this particular facility. Instruments should also be checked visually to make sure that they're not starting to break down, whether they've got scratches, whether they have pits, whether they have debris, as in the center lower picture and the upper picture will show particulates that are left on the devices. All of these things, again, can cause various complications that we've already identified. The scratching, the gouging, the pitting, the corrosion, all remove the protecting coating of the device as well, exposing what's in the interior. Then when it goes into the ultrasonic cleaner, it even has more of an opportunity to react with other metals. Damaged blade edges tear instead of slice. It hurts the healing, damages the quality of the healing. The bacteria hide in the pitted and scratched areas, making it difficult to really sterilize, starting on one of my favorite topics, biofilm formation in the protected area of the scratches and the pits. And then, of course, the emphasis again on not using hard water. It really, as you can see, of course, that's an exaggeration on the bottom right, but that's what it looks like if we could magnify it and really see deposits being left. So getting maintenance in there, explaining how important it is, and helping them see some of these pictures of what something like calcium deposits can do in the eye would be helpful. Use the right brushes. You don't have to use the one from the manufacturers, but make sure you mimic it, and that those the bristles are, give them a pull as you're starting to decide whether you want to buy them or not, to see if you're going to have anything coming out, because as you start to have in the little lumen, you may not see a residual piece of a bristle that can cause devastating effects within the eye. Staph decontaminated and reprocessed this phaco tubing on the right, and they found that the surgeon was actually upset. He was having problems with damaged eyes with TAS as well as non-infectious endothelmitis. And they kept saying, no, we're perfect, doing everything right. And he took it, as it was going into the patient, he took the tube and he sliced it open and found these particular chemical residues. which turned out to be causing the problem. So it's also an emphasis I want to emphasize right now is don't just go in once, but going in and out so that you're really getting all the surfaces. As you can imagine, when you brush your teeth, you don't just do it once down. There are so many things that can actually be missed if you're not doing a proper in and out. There's something else I wanted to say right there. And I have forgotten. Don't tell anybody. But I'll remember in a moment, I'm sure. And where else? Lint producing, what things have, in some of the surgery centers, they will tend to have it so that it's really comfortable for the patient coming in. And I totally understand that. You want to ease them. But bringing in things that would be lint producing, think about it. Do you really want carpet in that area? Do you really want high producing carpet on the outside that might be walked in to lint and particulates as they walk into the room where they're going to have the surgery, or they're brought into the room, rather? And making sure that the patient understands. Don't wear a mohawk sweater. Mohawk. That's the wrong word. Don't wear a sweater that would be linting or other things. And bringing in kids, I know that it's comfortable to have the teddy bear with them, but they produce lint too. So really going into the operating room and looking at what could be lint producing. Going into sterile processing, what could be lint producing? Do I hang my sweater up in there? Do I wear a warming jacket when I want to, a fleece jacket with the collars out? Just thinks that's probably an exaggeration for that particular area, but you get where I'm going. Trying to reduce any of the lint particulates. Patient apparel, the quality of the air filtration is very, very important, as we'll see in a moment. Corrugated boxes do not belong in any part of the either sterile processing or in the operating room because of the lint and particulates, as well as the organisms that can be in the units. On the bottom right, you'll see one of the containers. We need to make sure that we're scrubbing those containers. Very often, kind of don't necessarily, they look okay, so we miss things like this that could end up, especially in the activity that occurs during sterilization, perhaps they're going to end up on our instruments. And in the center picture, that picture of the calcium deposits, that just can't happen. And the water needs to be changed, as well as the maintenance of the unit lots more frequently. Cleaning with low linting disposable rags, low linting apparel in the housekeeping staff, the wet vacuum whenever possible, never use dry sweep. You must clean before you disinfect. Leave the disinfectant wet for the entire length of, it says on the IFU, and that's something we forget at home too. You know, it can't disinfect areas if it is not on there long enough. Keep the sterile storage racks clean, dust-free, secured from the traffic. Keep non-sterile storage clean. No corrugated boxes in the operating room or the device processing areas. Particles in lint, inadvertent insertion. These are pictures on the far right. You'll see a piece of lint that came out of the eye after surgery. That is, and not only, it took a little while. I mean, the patient had to come back and they found the lint in the eye and they pulled it out. And all those little, barely see little black marks coming down, pointing at the lint. That is where the white blood cells are already attacking it, is starting that inflammatory process. On the far left, you'll see both the suction devices in the cataract removal, but also the lens. Both of those have plastic, semi-plastic, or various materials anyway, synthetic materials that will attract lint. And I remember Dr. Stein, I believe it was, that found that powder, back in the days when we used powder on our gloves, would be attracted to the lens as he's trying to put it in, as well as to the sleeve holding the lens. So but that's a good visual for all the different types of particles that can be attracted to and cling to these types of synthetic materials. When they go in, then they want that, they're so excited to get the clear side on the right, but instead they end up with that picture on the left. Life is totally changed for them and may not be correctable. Golden years aren't then so golden. Drapes themselves, whether it's paper or cotton, both of these contain cellulose, and the cellulose and lint fibers are very bioreactive in the body, so we really want to make sure that we don't use those as much as possible. Spun lace is one of those terms that's used for something that has that paper side as well as the synthetic. Catheters, instruments, gloves dragged across the drapes disrupt the fibers and attract the lint. When you see the magnification that you see here with the cellulose, the cotton, and polyester, polypropylene was developed by manufacturers specifically to prevent the lint and particulates. And it's very, very important that we don't have lint and particulates getting in the eye. Absorbent drapes, often cellulose in the fenestration areas. Things that are drug against it, that's what that's about. Gowns, drapes, hair bonnets, tray liners, tip cushions, surgical towels, sterilization wrap, warming blankets, instrument tray liners. It's a big one. Unsealed sponge and gauze, back table covers, and terry cloth towels for drying. No, in the sterile processing area. But all of these things have contributed at one point in time to complications of lint and particulates. Also in the, as we were talking about before, in the carpets, in the furniture, in the curtains, patient apparel and hair, quality of air filtration needs to be checked. The quality of environmental services and cleaning their cloths, as well as the air circulation in the room. Fleece vests, the sweaters, the corrugated, the paper, which we had earlier. Some of the ways to look at what might be present, here's a tweezer example from the OR lights as they're moving those around. You can see the wood pulp and the polyester. The other that I showed you that was so tight and didn't lint was polypropylene. But here we have polyester. And here is actually from the loops themselves. So right above the surgical site when the doctor's looking over and found at the bottom right the wood pulp and cellulose fibers, which can be could be deposited into the surgical site or on the instruments used for surgery. This is collected by Dr. Edmonston right next to a surgical site. This is not eye surgery. This was in an open vascular wound and surgery. You can see on the left, that is the actual filter that he used and all the particulates that were collected. In the center picture is a magnification that he found cotton and wood pulp. And when you look at that magnification, you can imagine how little things that we can't see can really make a large impact as far as particulates. The debris and eye surgery in 2000 to 2003 for a 3-year period, a new surgeon was so excited about starting his new practice. So over these 3 years, he had greater than 100 cases of diffuse lamellar keratitis. A newly graduated ophthalmologist, all required resurgery, re-irrigation, and anti-inflammatories for those greater than 100 cases. As they continued to look, they finally found out, airborne debris was attracted to the electronic field of the ocular machinery. You can see it operating on the right, so that's going to go directly into the eye. The lint, particulates produced in fabrics in the procedure area, incorrectly installed filter in the ventilation system. So that's the other thing, that talking with maintenance. Is everything functioning the way it should? Are the particulates coming out of the filtration where it should be, all the particles should be out of that flow? Are they truly still coming through? And it took 3 years for them to actually do that study and find out that they had one piece that was rotated in the wrong direction of the equipment. And that's what caused the problem. And unfortunately, he lost his business He's written 3 articles anonymously to help other ophthalmologists avoid this problem. And then we have the guidelines. This is what the guidelines have said. All materials should be low lenting. And these are the guidelines for the operating room nurses for ophthalmics. Device attracted to the plastic sleeve, deposited in the intraocular lens with the intraocular lens on insertion, powder, lint, phakic debris, detergent residue. All of these things have been identified. The fibers can enter the anterior chamber during or after surgery, toxic anterior segment syndrome, the sterile ophthalmitis, toxic lens syndrome, and fibrosis can all be initiated by lint and debris. This is one, please, when they're doing their maintenance, ask the maintenance guy, if you can ask him, tell him that you need, the filter units, the filter materials, so like at home that we use. But you're going to look at the HEPA filter, and if it has a certain color, you can start to identify what may be causing some of the lint that is being picked up or may be present, and start to focus in on what you need to change. Also, these HEPA filters cost a lot of money, about $1,000 a unit, so take credit for it if you can decrease or increase the time of which they're still effective, because they're not being clogged by lint and particulates, because you've gotten rid of those producers. Utilize the appropriate ventilation. Do not block the intake and output air vents in the surgery room. Double check where the equipment is. Make sure they aren't blocked. Reduce the OR traffic. It's reduced infections in several hospitals, and there are many publications that talk about it. Keeping that door closed. Keep the delay final open of instruments until just before it's needed, because there are precipitates, and they have found just from the air, and they found that leaving those instruments open for the 15 minutes, 30 minutes, and an hour, they've actually clocked how frequently it can be contaminated, or what percentage of them are contaminated. Tuck the shirts in, especially men who really have a lot of the skin deposits, skin flakes that can contain bacteria present. Cover hair rather than letting that particulate fall out. Do not have lint-generating materials exposed in the OR. Don't let the patients wear lint-producing clothing, as we talked about earlier. This particular study had 214 infectious endothelmitis cases following cataract surgery, traced to the times attending the scrub nurse or the surgeon who wore no mask. When they tell you masks don't make a difference, studies like this, they make a big difference, and that they really cover the nose as well as the mouth, not just one or the other. Makes a huge difference, as we're even seeing in coronavirus. Okay, now we want to get into the brain surgery a little bit. I realize it won't be as much time because we spent most of it on eyes, which is important. Neurodegenerative diseases we don't want to forget about, however. Prions. Prions, the word is derived from protein infection. They just took those two parts, put them together. It's very, very unique. Its substance is known to be infectious, like viruses, bacteria, fungi, parasites. They have DNA or RNA that helps the memory process and to dictate how how the organism can become infectious. But over on the right, we see something called scabies in sheep. And what that is so special about him is that he's been infected with a protein. And the protein causes an infection that causes other proteins to be infected. It alters the shape of a specific protein on the neurons in the brain, the spine, the optic nerve of the eyes. These newly altered proteins then alter the next normal protein, as we'll see in a moment, and the impact spreads. Symptoms are first identified in sheep as scabies. But in the 1950s and 60s, the foray people in Papua New Guinea had a strange disease of their inhabitants. The kids at about 7 years old would start to have extreme weakness. loss of coordination, tremors, and unfortunately, severe wasting, as you can see, and death would follow every time. The cause, finally identified by the individual on the right, was a religious ritual to pay respect and carry the legacy of dead relatives. They ate their dead relatives' brains. And the children were the loved ones that were allowed to eat first, and unfortunately suffered these consequences. Since their discovery, there have been over 500 cases of diagnosed iatrogenic healthcare-caused transmissions in the United States. Prions contaminate growth hormones injections. Unfortunately, a large number of those cases, the kids were just trying to grow taller and were injected from the brain fluid that had the hormone in it, and the dura mater, and then also surgeries where they replaced the dura mater after doing brain surgery had been contaminated. So in both of those cases is where it had occurred. Likelihood of that significantly underdiagnosed globally, and it can progress rapidly, or it can take up to 50 years. So it's very hard to pinpoint what caused it in the first place. Well, this is what happens. What's called a PRPC, which is a protein that helps the cells to adhere together and also to communicate with each other. They believe it also may be involved with a brain communication between the cells and helps us in our thought processes. The normal molecules, then, this particular proteins dissolve and they're replaced routinely. So they just dissolve as they get old, and then other things, other of the same, come in and take their place. But unfortunately, when these misshaped proteins, and up in the upper left, you see a normal protein on the left, you see the misshaped protein on the right. The misshaped protein is a prion. That misshaped protein, maybe they've eaten some meat that had prions in it. Maybe they had surgery, or the things we just talked about that have added proteins. Then it starts to just multiply throughout the brain. And they call it the spongiform encephalopathy because it looks like a sponge inside the brain. Those proteins accumulate. They don't dissolve like the healthy proteins did. Unfortunately, they just keep multiplying. It gets so big, and then the immune system comes in, wipes them out, and you end up with holes in the brain. And extremely sad. These holes, the clumps before they become holes, the clumps are called amyloids. You've probably heard a lot of the word amyloid in brain-type diseases. Okay, so the next one shows us the misfolded proteins and what it does to the brain in the upper left, the normal brain compared to the CJD, Creutzfeldt-Jakob's disease brain with the prions. The loss of brain function resembles Alzheimer's. It's much more rapid in progression, complete dementia, approximately 6 months. Death follows quickly, always fatal. There's no known cure. This is a father of 2 sets of twins. They did not find out what caused it, but within a year, he went from the upper picture to the bottom picture, and that's 1 day before his death. Prion diseases in animals. So prions are a thing. It's not just for Alzheimer's, or it's not just for Creutzfeldt-Jakob's disease or mad cow disease or scabies. You can see all the different types of prion diseases. The protein is slightly different in each of these cases, and even those have what they call strains now, because right now they have a naming process. Chronic wasting disease in deer and elk and moose are up in our northeastern especially areas, and have caused fatal cases of prion disease. Kuru in humans is what we saw in Papua New Guinea. The mad cow disease, the feline spongylopathy, which we didn't even realize is also in cats and lions and tigers and pumas and ocelots and cheetahs. So this is a whole area of research right now to understand the disease and how you stop the disease. Obviously, antibiotics can't do a thing. It's possible but not proven that the other neurodegenerative disease like Alzheimer's, Parkinson's, Huntington's disease, and amyloid lateral sclerosis, otherwise known as Lou Gehrig's disease, all may benefit from this research that we're talking about. Like I say, the proteins are slightly different, but and the progress of the disease is different, anything from less than a year to over 50 years, depending on what they have. But all of them may really help to learn and prevent or learn and cure this disease at some point in time. The transmissible encephalopathy, one of the things that they've only recently found out is the picture in the center. You see the little dark, the brownish little clumps? Those are amyloids deposited in the retina. Remember how we saw how small that retina is up at the front part at 0.5 or half a millimeter? So they're being deposited in the eye, and now they found it in the optic nerve as well, so that some of the work that was done in corneal transplants, unfortunately, they pick up some of the proteins there and has caused the prions in that area. So the good part is it might be that they're working on a way to help us diagnose, help the physicians diagnose more rapidly someone who's got a prion disease. The negative part is, unfortunately, you can't use the eyes for transplants as had been done for people who had died previously and caused, unfortunately, the disease in the next person. So how can you get this? You can get it from inheritance for the familial is transferred. Not very many are, but that is one of them. Eating prion-contaminated meat, injections of contaminated fluids such as the growth hormone, surgery with contaminated instruments, contaminated injection fluids, implanting contaminated tissues such as the dura grafts, the corneal grafts, and the eye tissues, other eye tissues. Retina, cornea, optic nerve, lens, sclera, and elsewhere have now been identified if the person has a prion disease to be contaminated, especially towards the end of their life. Excuse me. Comparative frequency of infective organs. If you're cleaning something and you need to know what's the probability, they said that person had a prion type disease, well, it's the highest probability it could be contaminated if it had brain surgery, which is including the dura mater of that skin part, the membrane over the brain. The spinal cord, the posterior eye, and the pituitary gland are the primary areas. Lower risk with cerebrospinal fluid, liver, lymph node, kidney, lung, spleen, placenta, olfactory epithelium of people who have prion diseases and they've done surgery in those areas. It would be a lot lower risk of that having prions in it, the tissue, and thus contaminating our instruments. And they have declared no risk for all of these things, the intestines, the bone marrow, the whole blood, the leukocytes, the serum, the fluid, and it goes on with the various types of organs and tissues and fluids that have not ever been identified with the prion proteins. Okay. Excuse me. So, effectiveness of sterilization processes in inactivating prions. This is to really respect this infective protein. Not effective, deactivating it's less than 3 logs effective, so it's really not doing enough that it needs to do within 1 hour. And that would be the autoclave at standard exposure conditions for 15 minutes in this case. Boiling, dry heat, ethylene oxide, formaldehyde, hydrogen peroxide gas plasma with a steroid. This particular study was done with a steroid. The ionizing radiation and microwave and UV light. None of it would kill, but that's the wrong word. None of it would deactivate or destroy the prion protein. Those things that were effective was autoclave at 121 degrees centigrade for 1 hour using a gravity displacement sterilizer, or 121 degrees centigrade for 30 minutes with a Prevac sterilizer. Autoclave at 134 for 18 minutes with Prevac, 134 for 18 minutes immersion in water. The hydrogen peroxide plasma sterilization, sodium diductyl sulfate, SDS, and each of these at some level had been effective. Okay, but as far as disinfecting surfaces, and we'll do a little bit more on sterilization in a moment to be more specific, what's recommended. But let's talk about surface disinfectant for a while. Nothing has been cleared in the EPA for using any specific disinfectant to take care of prions. Ineffective, they have found that acetone, alcohol 50 to 100%, alkaline detergents, ammonia, chlorine dioxide at 50 parts per million, enzyme detergents, formaldehyde at 3.7%, glutaraldehyde at 5%, hydrochloric acid at 1 normal, hydrogen peroxide at each of those up to 60%, not effective. Isn't that amazing? Also, all of these, iodine, peracetic acid, at those specific percentages were not effective. Okay, so tell me what will work. And sometimes we'll see the same word, but with a higher percentage or a mixture. Alkaline detergents with specific formulations, chlorine at greater than 1,000 parts per million, copper, and you can go on and on with all of the peracetic acid again, but now at 0.2%. So there, you can deactivate them. You can deactivate them, but you need to know what to do. And the article that we are showing you is a SHEA guideline recommendation for prion-decontaminated instruments would be an excellent source to really hone in on what you want to use. So the includes only those that are scientific study. The SHEA group that developed this researched what World Health Organization also had, and they recommend 6 different options. But SHEA says that they included only those for which they felt that the scientific studies best demonstrated both safety for the equipment and the operator, as well as the efficacy to kill or deactivate the protein. So this is what they've come up with. Option 1 was to autoclave at 134 degrees centigrade for 18 minutes in a Prevac sterilizer. Option 2 was autoclave at 132 degrees centigrade for 1 hour in a gravity displacement sterilizer. Option 3, to immerse in 1 normal sodium hydroxide, and it tells you how to make it, for 1 hour, then remove and rinse it in water, then transfer it to an open pan and autoclave it, 121 degrees centigrade, as you can see here, and for an hour. And option 4, to immerse in 1 normal, again, sodium hydroxide for 1 hour, and heat in a gravity displacement sterilizer at 121 degrees for 30 minutes. Then clean and subject to routine sterilization. And it looks like I have failed to put in the rinse. After the 1 hour in sodium hydroxide, you should rinse it, because if not, they can hurt the sterilizer. Prion contaminated items. The recommendation is to immediately use. Sterilization should never be used, immediate use, what we used to call flash, for prion-contaminated items, and I think that's logical, but we need to reiterate it. Always discard single-use devices rather than reprocessing. It's not worth the risk. To minimize the environmental contamination, non-critical surfaces should be covered with a plastic back paper. So it's absorbent on the front with the paper absorbent. And I realize I'm talking paper here because of its absorbency. Something else if they also declare the absorbency. But on the back, to have that fluid resistant than plastic coating, so it's not getting on your surfaces. And these are with high-risk tissues that should be discarded and non-regulated medical waste. Okay, that was important that they emphasized non-regulated medical waste. I'm using the wrong thing. There we go. There are no EPA registered antimicrobial products, as we talked about. The SHEA recommendations are hard, non-porous surfaces contaminated with high-risk tissues should be cleaned and then spot decontaminated with a 1:5 or a 1:10 dilution of hypochlorite solution, chloride solution with wet contact time of at least 15 minutes. And emphasizing again, that's wet contact time. Not just that you put it on there and you wait around for 15 minutes and you come back and just, rinse it off. Maybe it hasn't been wet long enough. The hypochlorite working dilution must be used within 24 hours. That's always, not just for Prion, and then discarded as it loses its effectiveness. Never, and I'm going to emphasize this, a lot of people don't understand this one or haven't heard this one, never use hot water for making hypochlorite solution as it renders the chloride ineffective. Okay, that's at home too, where we tend to think hot water is going to help a lot of things. Not in this case. Do not use paper, cotton, or other cellulose-containing rags or wipers in the pail or spread the disinfectant solution, as they deactivate. They actually grab and deactivate the chloride solution components. It's okay for wiping off afterwards when it's all done, just not when you're trying to spread it. You can use something like a polypropylene at that point, which are in your canisters and things. Okay. And that is the end of our course. I want to thank you very, very much. I wish I'd had more on prions, but there's only so much time, and I figure more frequently we have eye surgery than we do prion patients. Thank you so much for focusing on your patients and preventing their infections and or their contaminants and their complications. They may not be able to tell you every time, but I'm telling you now, they are very, very thankful. Adjust as needed. Go back. Don't be mad when you see something. Don't try to hide something that's wrong. Just go ahead and fix it. That's exciting. That's what we're about. And that makes you a hero. Thanks so much. I turn it over to you, Lindsay, for any questions.
Wonderful, Wava. Thank you so much for providing that information. Can you hear me?
Yes, I sure can.
Okay, perfect. I did get a couple of questions come through. The first one says, and just a reminder to anyone who's tuned in, if you do have specific questions for Wava, you can feel free to submit them in the lower left-hand corner. There's a question and answers resource tool that you can submit any questions that you have for her. This question that came through says, tabletop ultrasonic cleaners used to clean ophthalmic instruments. The sterile water needs to be changed after each use, correct? Or what is the recommendation?
I really do recommend it be changed after each use and cleaned out. And that might be a great time to use your hydrogen peroxide, because it's really going to take care of the endotoxin, which is often missed, and then rinse it out. And when you were taught that question, it sounded like it was dedicated to the ophthalmic. So it's less of an issue to have to do the wiping out so thoroughly after each use, but you only are being positively active when you do it correctly like that. Needless to say, it is absolutely necessary if you have a mixed unit where they're also using non-ophthalmic equipment.
Okay.
Does that answer it? Or?
I think so. If the person who asked that question has any follow-ups, please feel free to submit them. Wava, if someone to learn more about this information, do you have any resources that you can share, or any additional presentations that you've put together that could potentially be sought out?
Certainly. In both of those cases, I have an expanding one on prions, and also already developed expanded one on ophthalmic devices. Be happy to share anything, as well as with each of those particular topics, inside the handout, it has the URL of where you can get some free information as well. But and also, if you're a researcher and you need help on some of the articles, I'm happy to give you a list of references.
Okay. This is more of a general question that came through. What's the best way to deal with prions?
Avoid them. That would be the best. However, you can't always do that. It's understanding what the patients are. So this is another time when you really need to be part of the surgical team, understanding the patient coming in. Do they have the symptomology of a prion disease? Do they not? If they do, then we go through the things we just talked about, making sure that we're cleaning them properly, making sure that we are not recontaminating our rinse water, and making certain that we are sterilizing them adequately. That's the very best way. As far as handling them with your hands or a surface on your skin, that is not going to cause a problem unless you're licking your hands or skin. It's really the instruments are going into the next patient. So I didn't mean to leave any thoughts that we're going to be panicked just because we're around prions. It's also eating the wild meat from the north has its risks.
Okay. This next question says, how often do we see CJD in the United States?
Oh, that's a good question. It's one I meant to look up just before this talk, and I did not. There is a talk, there is a book. I have it here. I had it here. Hold on one second. Hold that thought, Lindsay. That I highly recommend. Can you see that? Whoops, I just fell off my chair. Can you see this?
Yes. Are you okay?
That book, it's called Brain Trust, and it is an assessment in the United States about CJD, or I should say prions, and where they are and the cases that have occurred. So I highly recommend that book, and it's well written.
Okay, wonderful. And I can actually add a link to that book in the resources tool. So for anyone tuned in, if you log back in using the same link that you used to access this session, I'll put a link to that specific book, which will be there probably in the next hour. So in case you forget it and you want to reference it again, yes, absolutely. Okay, this next question asks about the CJD incidences in Canada. Do you have any references or resources that you can share about that?
I do have references. I can't tell you what exactly occurred just because it's not on the top of my head, but I have seen that there are cases and would be glad to have the references for that.
Okay.
And I can give them to you, Lindsay?
Perfect. Email them to me and I'll add them to the resources list on the screen.
Great.
Wonderful. And this next question says, can you share some insight that facilities should consider when putting a policy together for the treatment of prion-infected instruments? It's really boiling down what we had in the specific task force that went through to understand what they should do. The work by Rutala and Weber really does, for Shea, really does summarize exactly what needs to be done, and it is not that long of an article, but highly referenced, and I would recommend that. And it's one I have. I'd be glad to send to anybody, or if, again, we can always put it on the site. Lindsay. Okay, wonderful. All right. Wava, thank you so much for sharing your insights about this topic. It's certainly not a light topic to start the morning with, but definitely an important one. So we're so glad to have you. We're glad that you kicked off the Resist conference for us. Just so that everybody knows, there will be a 15-minute break in between each session. If you have any additional questions that you think of, maybe you're thinking about this topic later today or later next week, you can always reference Wava's contact information on that speaker bio tool on the right-hand side of your screen. Her contact information will be there. After this session, your screen will automatically transition you to the second session in today's conference. But as a reminder, there is a 15-minute break. So if you need to grab a snack, if you need to, check on the kids, the dogs, assemble a tray, do some exercise to get the blood pumping, whatever you need to do, feel free to do so. If the registration page appears for session number 2 and you've already registered, just click on the already registered link and enter your email address to be transitioned into the next session. We are so glad you're here. We're glad that you're learning how to resist superbugs and surgical site infections, and we will see you all in the next session.
Thank you very much, everybody.